There we go. Good morning, everybody. My name is Morgan Denny with the Institute of Clinical Excellence, and this is the PT on Ice Daily Show. Welcome to Clinical Tuesday. Today, we're going to be talking about long COVID. Now, for those of you who don't know, I am lead faculty for the primary care physical therapy course, but I also teach the short course that is online about treatment of the post-COVID patient. Now, I know that most of you are probably really sick of talking about COVID or hearing about COVID. But I just want to express to you that the people that are also really sick of it are probably the people who are still dealing with the effects of it. So we're kind of going to talk about that today and talk about a little bit of treatment management strategization, just so that we have kind of some ideas about where to start with these people and where not to start for that matter. So for those of you who don't know, long COVID, what is long COVID? So a lot of people who are getting a COVID infection of varying levels of severity and complexity are developing these long ongoing symptoms. Now they include a lot of different things, not just your standard cough, sore throat, shortness of breath, the stuff that we think of that is classic and goes with COVID-19 infection. They're also developing things that are like crazy levels of fatigue. They're developing GI issues, all sorts of headaches, these things. But one of the keys that goes with the definition, which there isn't truly one yet, of long COVID is that they have symptoms that last greater than 3 to 4 weeks. Now, the NIH, actually, the National Institute of Health, has recently termed it post-acute sequela of COVID, aka PASC. Kind of a hard acronym to say. But most people who have long COVID or who are dealing with it are terming it long COVID. And that's also what it's termed in most of the research. So we'll talk about it in those terms today. But basically, it's a huge constellation of symptoms, right? So a recent study, actually, it's not that recent anymore, probably 3 or 4 months ago, looked at 205 different symptoms over 10 organ systems. So we're talking about a huge host of different kinds of symptoms that are showing up for these people that don't necessarily mirror the normal COVID type symptoms, but come on, not even necessarily during their acute infection with COVID, but come on in the weeks and months following that infection and stay with them for a significant amount of time. So the top 3 basically symptoms that show up for a lot of people are fatigue, and we're talking about it in levels that are dysfunctional, so don't allow people to go to work or do their normal things. Post-exertional malaise, so very specific to activity, feeling like they are so fatigued they can't stand up anymore, or wow, I did a chore, so now I have to take a nap or rest for the rest of the day. And cognitive dysfunction, which is also being termed brain fog. So really just that inability to kind of think as you normally would, to converse with people as you normally would, to have that mental clarity. These are the most commonly reported. But there's also a recent study that came out that also says that shortness of breath is really, really common, sleep dysfunction and headaches are in the top 5. So it's kind of changing depending on where some of this research is coming from and what their population is. A lot of the research right now is coming from data off of apps, because there are a couple different governmentally run for research apps that people with long COVID or ongoing COVID symptoms can log into and then log their symptoms, because this is also new to the whole research community that we're still trying to figure out what's going on. So people are logging symptoms. So research may have different results slightly depending on who they're drawing from or where the population is for that matter. But these patients have symptoms all over the board, as I mentioned. So some other common ones are GI issues, anxiety, neuropathic pain like pins and needles into their feet and legs, crazy amounts of myalgias. I know several patients who, one of the things they found when they thought they were over their COVID infection was kind of all their previous injuries seemed to come out of the woodwork with a vengeance and with no significant reason. And it was really just this long COVID syndrome developing. People can also have chest pain, cardiac issues. A lot of people report palpitations, changes in menses. There's just so many things As I mentioned, there's 205 different symptoms over 10 organ systems that one research article actually looked at and documented for these people. So it's a myriad of stuff going on. Now, while we usually think about symptoms as attributed to severity of course of illness, right? Like, oh, you were in the hospital with really bad pneumonia. Now you have this significantly decreased lung capacity. Long COVID is something that's not tied to severity of illness. So some people who are developing long COVID had really minor cases of COVID. Some were even asymptomatic, but they were tested positive, and then over the weeks and months following that developed some of these symptoms. So this isn't something that we can actually link to a severity of course. Now, luckily, a very recent study that just came out like a week ago or so, pretty much looked at if there were factors we could use to predict long COVID developing from an acute COVID infection so that we could potentially screen out those individuals and then be able to put them on the best track possible. The only things they found were if you were female, you were more likely to develop long COVID. If you had a high BMI, you were more likely to develop long COVID. And increasing age also was related to an increasing risk of long COVID up to the age of 70. But they also attribute that to the potential that people over 70 aren't getting on the app, using the apps, giving the data the same way middle-aged and younger people are. The only other factor that could predict long COVID from an acute COVID infection is if the person reported 5 or more symptoms within their first week. So as I mentioned, with long COVID, sometimes people have really mild symptoms and then they develop these long COVID symptoms as time goes on. One of the predictors they found was if you had 5 different symptoms within your first week of infection. So for example, if you had a sore throat, chest pain, a cough, fatigue, headache, and GI issues, that's 6. So that would indicate that you may have a predisposition towards developing long COVID. So just remembering, this is all very limited information. It's like, even though, as I said, we're all sick of hearing about COVID and talking about it, it's also really very new still within the medical and research community. So we're still learning a lot all the time. We also know that this is very similar, this long COVID post-viral syndrome is very similar to ones that we've seen after other viral infections, including SARS, the original coronavirus. There were cases that developed of this type of thing after that. It's just that with SARS, the population that was affected was so much lower, and we got it under control, or it got itself under control so much faster that we don't see a lot of research about it because it affected such a less significant population as SARS-CoV-2 or COVID-19. So it's actually very similar in this thought. This long COVID-y thing has been around a while. It's just it hasn't affected enough people for us to do research on it until now. So there's a little bit more to the scoop. So for some people, just a small subset of people who have long COVID, they're developing symptoms that are really similar to ME/CFS. ME stands for myalgic encephalomyelitis, say that 3 times fast, and CFS is chronic fatigue syndrome. So this is a syndrome that's been around for a while, but doesn't have a lot of research behind it. So for people who have ME, we'll say ME because that's easier, CFS, basically they have crazy levels of fatigue and they have the inability to kind of do things. We're not talking fatigue like, what a hard day at work, I'm so tired, I need to lie down, or that was a really killer workout, I feel way more tired than I'm used to being. We're talking like, I decided to take a shower today and then I had to be in bed for 2 days after that because it was so fatiguing. Or I walked to the mailbox and then I couldn't stand up for the rest of the day. People with ME/CFS are not lazy, they're not deconditioned. They have this post-viral E type of condition that literally affects their energy level to such a significant amount that it causes levels of disability. They are just unable to do tasks because of this high level of post-exertional malaise, right? And this is happening for a significant amount of patients with long COVID as well, is they're developing these symptoms and research hasn't formally said oh, this is totally ME/CFS in the long COVID population, but they're developing symptoms that absolutely look and sound like ME/CFS. Now, The key here is that for patients like this, for patients who fall into this category, the biggest strategies are really rest and pacing. So basically the ideas of if your body is tired or feels severe fatigue, listen to it, take a rest. That's what we should encourage these patients to do. And the other side of that is pacing. So basically energy management strategies. So looking at your day, figuring out what your energy bank holds, and then being able to say, okay, I know I have this meeting at 3 p.m. today. So in the morning, I'm not going to do anything that exerts me or that is mentally or physically overstimulating because I really want to be on my game for my meeting in the afternoon. Or I would like to take my dog for a walk, in the morning, but I know that I can't do a whole lot the rest of the day because I'll be really fatigued after that. So using strategies like pacing are some of the only things that people with ME/CFS have actually found to be truly helpful. And so for us to understand that for this subset of patients is going to be key. So it's obvious, right? For these people, we've got to use caution. So when anyone comes in that has symptoms that seem, sound, look, smell like long COVID or post-COVID, as I've said before on this podcast, we have got to screen their vitals, right? Because anyone who has had COVID, independent of what they report symptom-wise, anyone who has had COVID has the potential for having some kind of cardiac injury, right? And who are we if we don't just take their blood pressure and their heart rate and their O2 and just look at what happens when we exercise these patients? Because if there is an underlying cardiac injury and we miss it, as the exercise prescribers, we could be doing something super dangerous for these people. But additionally, it's just a disservice to the patient that yet again, they saw another medical practitioner who didn't catch what was going on. So we've got to be screening vitals for these people. Now, secondly, anyone reporting symptoms of POTS or postural orthostatic tachycardia syndrome has got to have their vitals screened with position change. Now, POTS is a super debilitating condition for those who have it. It creates insane rises in heart rate and drops in blood pressure with just standing up after sitting off the couch or while cooking or going up the stairs. And when I say that, I mean people say like my heart is beating out of my chest or I feel like my heart can't keep up with me. And then I feel like I'm almost going to pass out all the time. But as that happens throughout the day, it can be really taxing and energy depleting for people who have POTS. And POTS is another symptom that goes with long COVID. A lot of people with long COVID are developing or reporting symptoms of POTS as well. So it's important for us as PTs, if we're going to be moving people, that we can then go in and test some of these things. So number one, vitals. Number two, if they report any symptoms of POTS, after you ask them, do you have any A, B, and C symptoms? We've got to check what's happening to their vitals as they change positions. Now, number three, even though we don't actually have guidelines, or we didn't originally in the States regarding long COVID, luckily the UK created some. So the NICE guidelines, one of the things that they suggest for people with long COVID, if the patient is still having respiratory or lung type of issues at 12 weeks post-acute infection, that person should get a lung x-ray just to make sure and screen out any continued lung consolidation or infection that is truly in the lung fields, just to make sure. That is what they recommend. Now, here's the piece that I think is most difficult for PTs to swallow. For the population that has ME/CFS, they are not going to do well with exercise. I know, boo, suck. But here's the thing. No amount of small, stair-stepped, tiny, graded exercise program that you think, if I just make it just a little smaller, just a little less aggressive, no amount of this is going to work. In fact, exercise for this population generally makes them worse and can cause relapses. And I'll tell you, even pre-COVID, I have totally screwed this up. Having had a patient who had undiagnosed at the time, but now I recognize it, ME/CFS, and I thought, okay, we're just gonna make it more minute. We're gonna change how we do it. We're gonna spread it out. No, it always just floored her. It always made her crazy fatigued and made her pretty much have to erase a whole day of her life. Even tiny, tiny, tiny amounts. So trust me when I say with experience, this population does not respond well to any kind of exercise. Now, also in a study they looked at with 4,000 people reporting symptoms with long COVID, 70% of them reported a relapse or worsening of symptoms with physical activity or exercise. 70%. That's not 10%. That's not 1 out of 10. That's a huge proportion of this long COVID population, right? So we've got to keep this in the back of our mind because these people are going to be seeking us out. They feel deconditioned. They feel weak. It's been months since they were able to do something. Maybe they just need some good old-fashioned strengthening. Maybe they just need to see a physical therapist who knows a little bit more to get them healthy again. They don't necessarily know, right? But people are going to be seeking us out, and we've got to have this information on board so that when that population shows up, we're not doing them a disservice. Now, I'm not saying that every person with long COVID will fit into this category, right? Will not respond well to exercise, will have POTS, will have ME/CFS, but there's going to be a significant population of these people that are going to be showing up who are going to be telling us about the insane levels of fatigue, the months of brain fog, the difficulty word finding, the unknown and unforeseen GI issues, the chest pain that every doctor has screened through and it just won't go away and they don't know where it's coming from, right? We've got to know that if we take these patients and we're starting to add exercise and we're not seeing a good response, it could be because they have some form of ME/CFS and that they're not going to do well with exercise. And we need to be able to step back and provide education and referrals and resources and ideas behind all these things that are going to be helpful for this population, even if it's not our thing, exercise, right? Like, I think it's good as PTs to realize like exercise is our mainstay and that is awesome. But there are times when it's not appropriate and we've got to be able to recognize that. Now, on a positive note, a lot of these people are really getting better and improving. For a lot of them, it's taking a really long time. We're talking months and months and months, like 6 months, 9 months. I know patients who have been dealing with symptoms for over 12 months now. So we've got to realize like a lot of these people get better, but it takes longer than anybody wants it to, us and the patients, right? The other thing is many people, not everybody, but many people who get vaccinated who have long COVID are seeing a crazy improvement in symptoms. So anyone you know or who are treated who has long COVID, encourage them to get vaccinated. The biggest thing people are saying is that it's really improving their brain fog, which is like lifting a veil off of their mind, so they can think clearly for the first time in a long time. So encouraging people to get vaccinated is super important, especially in this population, or I should say additionally in this population. As the other thing is, not that these are prevalent everywhere, but there are some long COVID rehab facilities that are popping up around the country as we're really recognizing that this is a population that's existing, right? So long COVID is something that they've guesstimated anywhere between 10 and 30% of the population that has had COVID will develop long COVID. So of the millions of people who have had COVID, 10% to 30% is a lot of people. So they're starting to develop some of these long COVID rehab centers that are very holistic, that include PT and OT and speech and, primary care and stress management and counseling and all sorts of things that can really help these people. So if there's one of those in your area, remember, use that as a resource. You don't have to be the hero. Referring to the right place makes you a really good practitioner, right? Now, we have to keep in mind that some of these people will still have symptoms, even after a year, even after treatment, even after vaccination. Like long COVID is a very frustrating condition for people and has truly affected a lot of lives in ways that I think none of us could have imagined. But we've got to keep some of these strategies and frameworks and ideas in mind because some of these people are going to be status quo a year post-COVID, but still showing up at the clinic for low back pain. So we have to keep this stuff in mind as we're seeing these patients, not because you're not going to treat the low back pain, but because if you have more information and you have a better ability to screen out some of these things, not to mention understand how to strategize your exercise program or potentially not have a true exercise program, That's important, and that's going to make you more effective with these patients and help them get better faster. Okay, I hope that is helpful. If you find yourself treating a lot of patients post-COVID and you need more guidance, please check out ICE's online management of the post-COVID patient course. And also, if you're more interested in jumping into some of the medical things involved with PT, feel free to jump into the primary care course. Our next cohort starts in about a week, and there are about 3 spots left. So feel free to jump into that. And otherwise, I hope you all have a great Tuesday. The song of the day is Honey Body by Kishi Bashi. All right, everybody. Peace out. Have a good one.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.